Mohan, you're in hospital
Yes.
In the scrub suit.
in the scrub suit. What time do you go home generally?
Around 9.
Oh, so it's early right now.
Early.
So, sir, I'm in a lecture till 9 o'clock. अभी I'll not be taking the call. नहीं तो फिर आपको एडमिट होना पड़ेगा अगर ऐसा है तो you have to come to the
I think you start now. It's 8 past. Huh?
Shall I start?
Yeah, start.
Start.
Mm-hmm.
Am I audible?
Yes.
Yes. Good evening. Dr. Mohan Ramchandrani, who is the Director of Interventional Endoscopy in Asian Institute of Gastroenterology, to moderate the session. I would like to hand over the mic to Dr. Mohan, please.
Thank you, Sudipta. And at the outset, I thank Gemas, led by Dr. Sujit Chaudhary, for giving me this wonderful opportunity to be a part of this very academic interaction. And today we have a second GMAS masterclass, and this is a very important topic, which is a lower GI bleed. And our guest speaker tonight is Dr. Vineet Ahuja, who is Professor of Gastroenterology and also Associate Dean Research in AIMS, New Delhi. He's also editor of Tropical Gastroenterology. He's also a very active member of International Organization of Inflammatory Bowel Disease. So we are very fortunate to have him. He's a known faculty and a very good friend. We will also be having two of very prominent faculty as panelists to carry on this discussion. Dr. Dev Kumar Ray, he is consultant GI and advanced laparoscopic surgeon at Amri Hospital, Salt Lake, Kolkata. He is trained in upper and lower GI surgery in Wessex, Dinnery, UK, and he is practicing GI surgeon for last 20 years at Amri Hospital, Kolkata. We'll also be having Dr. V.M. Dayal, who is very good friend and is also alumni of BHU, from which I also belong. So it's a great privilege to have Dr. V.M. Dayal. He's presently professor and head of the Department of Gastroenterology at Indira Gandhi Institute of Medical Science at Patna. And he has got many publications and chapters in international and national renowned journals. I think we'll have a very good team of Dr. Vineet, Dr. Dev Kumar, and Dr. V.M. Dayal to carry on this discussion, especially aiming at our postgraduate students. Dr. Vineet, kindly start your lecture. Thank you very much.
Thank you, Mohan. Thanks a lot. And first of all, I'd like to thank Dr. Sujit Chaudhary and Gemas for this opportunity. The topic today is acute lower GI bleed, a case study. And as I gather, this is mainly a class which is meant for DM, DNB students. Now, before I start this topic, I think when we talk about GI bleed, whether upper GI bleed or lower GI bleed, one should remember this line. This line, I think, I don't know who said this line, but it is good judgment comes from experience, and experience comes from bad judgment. It clearly tells you that you learn all along the way when it comes to GI bleeds. So our case is a 40-year-old male who presented to us in August 2019. He had history of chronic alcohol abuse. He had an ultra. He was carrying an ultrasound which showed that he had cirrhosis, chronic liver disease. He presented with maroon-colored stools, suggestive of probably lower GI bleed. We were not very sure. He also had jaundice as well as ascites, portal hypertension, varicose status that had not been evaluated earlier. This patient had severe GI bleed. He had orthostatic symptoms. He had fresh blood plus maroon colored stools. And as I told you, etiology, we thought that it would be varicose bleed, although he had fresh blood. But at the same time, since he was having maroon colored stools, so we thought that he's having torrential bleed, it could be varicose. And we also wanted to look at for acute on chronic liver failure and rule out spontaneous bacterial peritonitis. So when he presented to emergency with severe bleed, two large bore IV cannulas are put in. Normal saline was rushed in, blood grouping was done. He was started on terlipressin as well as pantoprazole infusion. Blood transfusions, two packed RBCs were arranged and given. He had very poor GCS, hemodynamic instability, so he was intubated, and in fact noradrenaline had to be started. Subsequently, immediately an endoscopy was done. Endoscopy showed large varices, grade 3 varices. However, as you see, there were no red color signs and there was no blood out there. 3 EBL bands were applied. There were no fundal varices, but he had maroon oblique melenic kind of stool which persisted. So the next day, a repeat endoscopy was done, which showed bands in C2 at lower end. Again, no blood. Stomach did not show any bleed. No fundal varices. In fact, there was bile present, clearly suggesting that although the patient is having blood loss, but at the same time, the cause does not seem to be upper GI. Investigations showed hemoglobin, which was rapidly falling. It had decreased from 6.1 to 4.5. Then subsequently, despite blood transfusion, 3.2. And then after 4 units of PRBCs, it went up to 7.2. Leukocytosis was there, thrombocytopenia was there, a creatinine level which was already high at 2.7 with enzymes which were 93 by 18 and a bilirubin of 2.6. INR was 4.6. ABG done showed a pH of 7, lactate of 10. So immediately after endoscopy, when the bleeds for, although it was still continuing, he was taken up for hemodialysis, and hemodialysis was given, and subsequently his pH, subsequently it improved. So when you want to localize the bleeding source, this has been classical teaching in MD, or I would say even in MBBS, that if there is fresh bleed from per-rectal fresh bleed, which is separate from stools, with or without rectal symptoms, you would think in terms of anorectal bleed. If there is bright red or maroon colored bleeding per-rectal without normal stool and without hematemesis, then the source can be, most commonly you would think of lower GI bleed. However, it can also be mid-GI bleed. What do we mean by mid-GI bleed? Upper GI bleed is bleeding which is proximal to the ligament of Treitz. Lower GI bleed classically is somewhere you can say from terminal ileum till anal canal. And in between region, that is jejunum onwards till terminal ileum, that is proximal ileum, distal ileum, you can say till distal ileum, that is the area which is for which the terminology uses mid-GI bleed. Since the patient was having bright red or maroon colored bleed, one would think of lower GI bleed or mid-GI bleed, but at times, in fact, it has been seen in 15% of cases of lower GI bleed, the cause could be upper GI, where the patient may present with bright red or maroon colored bleeding. And usually these patients have hemodynamic instability. The possible cause could be ulcer bleed or portal hypertension. Then you have what is known as a classical melena, that is black tarry, foul offensive colors, smelling stools without any hematemesis. If it is there, then also you would try to think of upper GI bleed as a commonest. Occasionally, it may be ileocecal or right colon, or at times can also be small. So that way, this kind of strategy helps us to localize the bleeding source historically, but it is not true in around 20-30% of the situations. So our discussion points today would be, when such a kind of case comes, we'll follow the case also, that initial assessment, there would be 3 points: risk stratification, hemodynamic resuscitation, and management of coagulation defects. Diagnosis: what are the diagnostic techniques we have, and how are we going to utilize them? Concomitant medications: what happens to them? Do you stop them? Do you continue them, or when do you restart them? And situations like recurrent bleed and diverticular bleed and all. So first point, that the moment a patient comes to emergency, the moment you see a patient whereby you feel you categorize the patient as having lower GI bleed, there, while you are assessing the patient, while you're resuscitating the patient, you also need to do a digital rectal examination. The severity can be assessed by, first of all, calculating what is known as the shock index. Shock index is heart rate by systolic blood pressure. Do we really need to calculate the shock index? Is it something which is theoretical, or is it something which can be done or should be done? I think if you go along with the algorithm, you will find that categorizing a bleed as stable or unstable is the foremost thing which needs to be done. And shock index, which can be simply, which is a simple bedside calculation, heart rate by SBP, that is systolic blood pressure, that actually helps you in prioritizing, because shock index has been associated with mortality. Shock index has been associated with intervention, and in fact, shock index has been associated with also the amount of extravasation of blood. So it has such a simple index, and it can provide you three kinds of information. So obviously it is very important. So the moment you calculate the shock index, if it is more than one, that is heart rate is much more than systolic blood pressure. In other words, heart rate, let's say above 110 and systolic blood pressure of only 100. Will be categorized as unstable GI bleed, and obviously that means active bleeding is continuing. If shock index is less than 1, then it is stable GI bleed. Remember that there is a caveat that patients who are receiving beta blockade, obviously this may not be very accurate. So that is a history you would also like to take before you calculate the shock index. But again, remember that this is not a theoretical concept. This is a very practical concept, because within a second, it gives you an idea that you're dealing with a stable patient or an unstable patient. The stable patient can subsequently be again categorized as having a major risk or a minor risk. For this, you will have to calculate another risk score. Now, is it important at this time to have another theoretical risk score to come into play out here? Would it really help? Yes, it does help. This is another risk score. I'll talk about it in the next slide. But this risk score tells you it's a major bleed or a minor bleed. Stable bleed. But within the category of stable bleed, is it a major bleed or a minor bleed? If it is a major bleed, you have to admit the patient. If it is a minor bleed, then you can discharge the patient. In other words, you need not admit the patient. You have to just plan what kind of interventions have to be done so as to find out the source of bleed. How do you calculate the risk score? Which risk score is the best, and are they very tedious? Are they very difficult to calculate? No, it doesn't seem to be so. We have two scores. One is Auckland score. Auckland score has been specifically designed and validated for lower GI bleed. It is not that something has been designed for upper GI bleed and then you extrapolate it for lower GI bleed, which happens in many of the cases. But here, particularly for the risk score, Auckland score has been designed for lower GI bleed. There's another score which has come up, which came up just 2 months back, that is ABC score. And both these scores are very easy to use. So I'll go through both of them, but generally people use Auckland score till now. First, I'll talk about ABC score. ABC score is a new score that predicts mortality, not only lower GI bleed, but with both upper as well as lower GI bleed. This study came up in gut around 2 months back. And this study is remarkable because of the sample size, around I think 2,000-3,000 cases of upper GI bleed, another 3,000 cases of roughly upper GI bleed, as well as lower GI bleed, where it was validated. And the score is ABC. So A stands for age, B stands for blood test, C stands for comorbidity. So age, blood test, that urea is high, albumin is low, creatinine is high, and comorbidities in terms of mental status, liver cirrhosis, malignancy. ASA score, ASA is the American Society of Anesthesiology score. So this score can predict mortality very clearly. So this can be useful. But Auckland score is another score which is very easy to use. It is available on Medcal, so it is available on the apps and all. So in the emergency only you can calculate it very easily. It has been validated clearly for triaging, and this is again based on straightforward variables: age, gender, previous LGI bleed admission, pulse rate, heart rate, systolic blood pressure, hemoglobin. All very simple factors. And if the patient is scoring less than 8 points, you can clearly decide not only this is a stable bleed, this is a minor bleed. In other words, the patient can be sent home. If the score is more than 8, then the chances of subsequent bleeding, subsequent interventions are very high. So that is those are the kind of patients that you would like to admit. Now, while you are taking history, evaluating the patient, remember, this line seems to be very simple. This line seems to be like what's there to learn in this line, but actually this has to become a reflex for most residents, because most often what happens is they simultaneously then do not do assessment as well as resuscitation. Either they would be resuscitating or they would be assessing. So if it is possible, initial patient assessment and hemodynamic resuscitation should be performed simultaneously. Now, when you are resuscitating with fluids, it is very clear now that IV fluid resuscitation should be done with crystalloids, not with colloids. Colloids do not improve the mortality rate. This has a change which has come up over the last decade. Earlier, it was thought like, what are crystalloids? Crystalloids are like Ringer lactate, normal saline. What are colloids? Colloids are like hydroxyethyl starch or hemaxyl or albumin. So it has been seen that colloids do not improve the mortality rate. They are more expensive as compared to crystalloids, and clearly crystalloids should be given. So these are very simple points, but I am stressing upon these points because often we get confused between these simple points also. Third thing is how much to transfuse. Do we transfuse all or how much to transfuse? So now this is a strategy which has been extrapolated from data on upper GI bleed. For this strategy, direct data for lower GI bleed is not available, yet at the same time, most groups would use this strategy for, which has the data has come up from upper GI bleed, would use it for lower GI bleed also. So restrictive strategy, liberal strategy. Studies have clearly shown that a restrictive blood transfusion strategy whereby you maintain a threshold of 7, you do not want the hemoglobin to be less than 7, but you do not want to be going it up to 10 or something. You would want to maintain it between 7 or maybe up to 9, but somewhere in the range of 7, 8. There, it has been seen that restrictive strategy actually helps in reducing mortality. It also reduces the rebleed rate. Liberal strategy increases the mortality. It increases the rebleed rate. Liberal strategy is you want to maintain hemoglobin of at least 9, 10 and all, as it used to be done around 5-10 years back. That okay, if a patient has come transfused 4-6 units, maintain a hemoglobin above 10. No, that is not valid anymore. However, there are certain caveats as outlined out here, that most cases use a restrictive strategy, use liberal strategy if the patient has ischemic heart disease. If patient has a possible delay in receiving therapeutic interventions, there you would like to use a liberal blood transfusion strategy. What about platelets, fresh frozen plasma? Do we need to give them in all cases of lower GI bleed? If platelet count is less than 50,000, patient is continuing to bleed and you're planning endoscopic hemostasis, it may be prudent to give platelets. Along with platelets, you may also give fresh frozen plasma. Now, when it comes to what is massive transfusion, because for a massive transfusion, there's a ratio. I'm sorry, this is written as ration, but this is ratio. So massive transfusion is, it is defined as 10 units of blood within 24 hours or 3 units of blood within an hour. This is a definition which has been picked up from trauma settings. So it is not specific for lower GI bleed, but yes, at the same time used in any case, upper GI bleed, lower GI bleed, trauma setting. When you're giving 10 units of blood in 24 hours or 3 units of blood within an hour, that is massive transfusion. If a patient is undergoing massive transfusion, then you have to give not only packed RBCs, you have to give platelets, you have to give plasma. What will the ratio you would like to use? Earlier, the ratio which was used was 1:1:2. That is 2 units of packed RBC and 1 unit of platelet plasma. No, it has been seen that 1:1:1 ratio is best for platelets and plasma and blood. And this is again something which we often tend to forget whenever a patient comes with severe GI bleed. So this is something, there is a point to be, I say that we should remember, because this really improves the outcome. Finally, like, if you find INR to be more than 2.5, then there is an issue out there. If the INR is less than 2.5, till a cutoff of 2.5, that is reasonable for endoscopy in the acute GI bleed setting. However, if the patient is on warfarin, patient is on direct acting oral anticoagulants, that is the newer oral anticoagulants like dabigatran or ivoroxaban and all, then INR may be more than 2.5. And if the patient continues to bleed or you're planning endoscopic intervention, then in that case, reversal of anticoagulation may be required. Some groups do it, some places, some centers do it. If you want to reverse INR, which is high because of warfarin, that is vitamin K antagonist, then in that case, you would like to give vitamin K, which can be given over 1 hour intravenously, but remember that it may have a tendency to cause some kind of anaphylactic reaction. So you have to be very careful when giving it intravenously. Otherwise, fresh frozen plasma can be given. Prothrombin complex concentrates can be given, but they are expensive. For direct acting oral anticoagulants, you have idarucizumab is available or andexanet is available. Otherwise, apart from that, oral charcoal, if oral acting coagulant has been taken within past 2 hours, can be used, or hemodialysis can be used. So these are certain strategies which can be used if the patient continues to bleed. INR is more than 2.5, and because if the patient has recurrent or incessant bleed, then you may like to take this strategy. Now let's come back to our case. Just to revise, 40-year-old male, chronic alcohol abuse, chronic liver disease, cirrhosis, came with jaundice, ascites, maroon-colored stools. We thought it was varicose bleed. He underwent endoscopy twice, showed varices, but no bleeding point out there. So the next thing was that the point was obviously let's go ahead and do a colonoscopy. So the patient was taken up for a colonoscopy. Colonoscopy showed that rectum, transverse colon, ascending colon, everything normal. Blood was coming from above ileocecal valve and there were no hemorrhoids. So we were not very sure whether it is the bleed had stopped and this was blood which had regurgitated upstairs, or it was fresh blood which was coming from the small ball. So now what all to do in terms of let's come back to now the strategies. How do you diagnose a case of lower GI bleed? We have defined lower GI bleed. We have defined the risk score. We have defined whether it is stable, unstable, and if it is stable, then whether it's a major bleed or a minor bleed, how much blood, when to transfuse blood, how much blood to give, how much FFP to give, how much platelets to give, and how to correct INR. Now comes the diagnosis, that what are the causes and how do you diagnose them. If we look at causes, then their causes seem to be slightly different for India as compared to causes in Western countries. In Western countries, the most common cause is diverticulosis, followed by ischemic colitis, hemorrhoids, colorectal polyps, angiectasias, post-polypectomy bleeds and all. Basically, diverticulosis, carcinomas, polyps, post-polypectomy bleeds, ischemic colitis, angiodysplasias. In India, whatever series we have had, so there are around 7 or 8 series we have had. I put up around 4 series out here. You find that there are causes like non-specific ulcers, ulcerative colitis, acute colitis, inflammatory lesions. But very importantly, what you find out here, that diverticulosis is actually still not considered as a common cause. Now, these series are around 5 years old or 10 years old or 15 years old. So maybe the disease epidemiology is changing. But yes, at this with the available of whatever published data is there, you would see that diverticulosis is not a common cause, whereas diverticulosis is a very common cause in USA. While taking history, again, like I'm go through this slide very fast because this we have discussed that blood separate from rectum, hemorrhoidal bleed, bloody diarrhea associated with fever and pain, infective colitis, diverticular bleed. You should know the setting. Elderly individuals. Bleeding is usually abrupt, painless, large volume. Patient may give history of antiplatelets or NSAIDs. Ischemic colitis, patient with atherosclerotic vascular disease, heart disease, acute onset crampy abdominal pain, urge to defecate and all. Ulcerative colitis, Crohn's disease, they will present with diarrhea along with blood loss or abdominal pain. Colon cancer, alteration of bowel habits, weight loss, age more than 50. Remember that there are certain conditions predisposing to lower GI bleed. If a patient has chronic kidney disease, there are chances of angiodysplasias. If a patient has atherosclerotic vascular disease, ischemic heart disease, atrial fibrillation, there's a chance of ischemic bowel disease. If a patient has a family history of telangiectasia, there's a chance of Osler-Weber-Rendu syndrome. And particularly if you can find telangiectasias on the mucosal surface also. Blue rubber nevus syndrome, family history may be there. Colonic polyposis syndrome, family history may be there. Portal hypertension, post-endoscopic resection, post-radiotherapy, radiation, colitis, proctitis, they may also predispose to bleed. Drugs. There are certain drugs which have a high risk of lower GI bleed. And if we go from highest risk to lowest risk, then we find if we try to arrange them in that order, then you find that combination therapy, a patient is on anticoagulants, antiplatelets, may also be taking NSAIDs or something, they have the highest risk of bleed. Subsequently, direct acting oral anticoagulants. They have a high risk of bleed. The risk of bleed is more for lower GI bleed as compared to upper GI bleed. It is like dabigatran, rivaroxaban, or apixaban, in which dabigatran has the maximum risk and apixaban has the least risk amongst these three. Antiplatelets, all of them have a risk of lower GI bleed, but prasugrel has a greater risk as compared to clopidogrel. NSAIDs and aspirin, high risk. Non-selective COX-2s have the highest risk. Calcium channel blockers as well as SSRIs, they all can lead to lower GI bleed. Coming to next question now. We have taken the history. We have a fair idea of the epidemiology of lower GI bleed in terms of causes, which are seen in Western countries, which are seen out here. We know about the settings like chronic renal failure and ischemic heart disease, which may be associated with lower GI bleed. We also know of drugs which can predispose to lower GI bleed. This is all important because while you are assessing the patient in resuscitation, it is important. You have assessed the patient, you have resuscitated the patient. Now the question is, should colonoscopy be the initial investigation in all lower GI bleeds? Is it true or not? Now this is interesting because this is something which has again come up over the last few years. We talked about shock index, and we said that on the basis of shock index, which was simple heart rate by systolic blood pressure, if it is more than 1, it is unstable bleed, less than 1, stable bleed. Now, shock index not only predicts active bleed, predicts mortality, but it also predicts that extravasation of contrast on angiography in lower GI bleed. If a shock index is more than 1, then the chances are that there's a high chance that you'll be able to pick up extravasation of contrast on angiography. So it identifies patients who have active bleed and who are likely to benefit from CT angiography. So in fact, the algorithm is changing. The algorithm is that if the patient is unstable, if the patient is not getting stabilized, then the first investigation of choice should be a CT angiogram. It should not be colonoscopy. If the patient is hemodynamically unstable, shock index of more than 1 after initial resuscitation, and active bleeding is suspected, CT angiography provides the fastest and least invasive mean to localize the site of blood loss before planning endoscopic or radiological therapy. Now I come to the stable bleeds. In stable bleeds, my question is now at the other end. If we have decided a patient has minor bleed, we calculated the risk score. How did we calculate that? We calculated that with the help of Oakland index, but we also had the recently propagated ABC index. Any of those two scores, you can Oakland score or ABC score. Now, once it has been decided on the basis of those scores that it is a minor bleed, so obviously we said that if it is a minor bleed, you can discharge the patient. If you're going to discharge the patient, are you going to do a sigmoidoscopy or colonoscopy in that patient or not? Yes, you would do it. It is just that you will not do it urgently. Anybody who is over the age of 50, the risk of bowel cancer is high. In fact, 6% of patients presenting with lower GI bleed have an underlying bowel cancer. So it is very important that all patients, even with minor self-terminating bleed, be investigating. So it is not only bowel cancer, those patients may be presenting with ulcerative colitis, those patients may be presenting with just hemorrhoidal bleed, or so either way, it needs to be investigated. So again, revising till now what we have learned: patient presenting with LGI bleed, assessment, fluid recitation, calculate shock index, more than one, go straight for CT angio. Do not go for colonoscopy out here. Stable lower GI bleed, shock index, calculate Oakland score. More than 8, admit the patient, and the patient now needs to be planned for an early colonoscopy. How early, we'll discuss. Less than 8, consider discharge, and within next 1 or 2 weeks, you can plan all your procedures. Now comes another question. The question is that do patients with lower GI bleed, do we need to exclude an upper GI source? Is upper GI scopy should be done in every patient with lower GI bleed where you clinically suspect lower GI bleed, or in some cases of lower GI bleed, or should not be done? It has been seen that if a patient of lower GI bleed presents with hemodynamic instability, or if you have blood urea nitrogen or the blood urea nitrogen by creatinine ratio more than 30, or nasogastric aspirate, obviously if it is coffee ground, then it will suggest that the source of bleed is not lower GI, it is proximal to the ligament of trites. It is just that there is a torrential bleed going on. So nasogastric aspirate is obviously no-brainer. In other words, if a patient has hemodynamic instability, this tells us that you have to put a nasogastric tube in that patient, because if you aspirate coffee ground or blood out there, you know you're dealing with a case of upper GI bleed. You need not straight away take up the patient for upper GI. If a patient is not hemodynamic instability, then it may not be necessary in every case to put a nasogastric aspirate, particularly if you are having bright red blood per rectally and all. And secondly, if you get a urea by creatinine ratio, which is normal, which is not like normal in the sense it is not more than 30. So in other words, the recommendation would be lower GI bleed associated with hemodynamic instability may be indicative of an upper GI source. And if the patient stabilizes after initial resuscitation, then gastroscopy should be done. Comes the next important point: when to time your colonoscopy. Till now, I would say the knee-jerk response till now, at least till 5-10 years back, was as soon as a patient comes, as soon as possible, take up the patient for colonoscopy. Sometimes earlier the colonoscopies were done in the night, and 20 years back or 25 years back, when fiber optic colonoscopes were available at most places, then also colonoscopy was done unfavored and in night, and you could imagine what one could see with that fiber optic scope in an unprepared colon. So those things have totally changed. So the first thing is that is urgent colonoscopy beneficial or not? We'll discuss that in next slide. Before that, let me just give you the gist in one line. More than the timing of colonoscopy, bowel preparation is much more important. Nasogastric tube, if it has been placed, it should be continued to be placed so that it will help you for bowel preparation, because you need to give large volume preparation. So the point to be taken, the message to be taken from this slide is very, very clear. Bowel preparation rather than timing of colonoscopy. Why? Because till now we had meta-analysis, we had 1 or 2 small studies, then we had some sort of retrospective data. But this year, only in June, in gastroenterology came out the trial, which everybody was waiting from last 2 years. It's a Japanese study which looked at efficacy and safety of early bleeding versus elective colonoscopy for acute lower GI bleed. And this was at around 170 patients, where there were 2 groups: colonoscopy done within 24 hours after hospital admission, and colonoscopy done 24 to 96 hours after hospital admission. These were the 3 outcome measures, and this is the difference, the delta between the 2 groups. There was no difference in terms of spotting out signs of recent hemorrhage, whether colonoscopy was done early or late. There was non-significant difference in the rebleeding rate, non-significant difference in the transfusion rate in early versus elective colonoscopy, clearly suggesting that colonoscopy timing, early colonoscopy does not provide much benefit. So if you can stabilize the patient and actually prepare the patient, that is the most important factor, and then you can go ahead and do the colonoscopy. So how do you prepare? You need to actually give large volume, 4 to 6 liters, which 6 liters may be a little impractical, but definitely around 3 to 4 liters. Rapid 3 to 4 hours purge protocols using PEG-based solutions. Colonoscopy can be performed within 1 to 2 hours of preparation completion, but if you're planning to sedate the patient, and obviously then you would need around 3 to 4 hours of gap out here. And if you give large volume preps, then there is a high rate of definitive diagnosis, high rate of hemostasis. But remember out here that whenever you're giving large volume preps, and particularly if you're giving through nasogastric tube, or if there is any kind of sensorium impairment, there's a risk of aspiration pneumonia out here, and you have to be very clear about that. But at the same time, the recommendation is very clear that unprepped sigmoidoscopy or colonoscopy in the setting of acute LGI bleed is no longer recommended in 2020. That is something which is a product of bygone era. Today, you have to, as has been shown, that early colonoscopy does not help. So you have time to go ahead and prepare the patient and go ahead and do the colonoscopy. Why? If the patient is unstable, you will ask, if the patient is unstable, then what do I do? Will early colonoscopy not help? Then in that case, as I told you before, simply calculate the shock index, heart rate by SBP. If it is the patient is unstable, go ahead with the CT angiography. That would provide as much data as you may perhaps get by a colonoscopy, which at that stage. If you are going to do a colonoscopy, obviously there are certain caveats in terms of hemostatic measures. Now, these hemostatic measures are actually extrapolation from the upper GI bleed data. There's no head-to-head RCT of endoscopic therapies for lower GI bleed. Carbon dioxide insufflation should be done. That should be used while performing these procedures. High-risk endoscopic stigmata of bleeding, like active bleeding, non-bleeding visible vessel, adherent clot, they need to be taken care of, because if they are there, then endoscopic therapy should be done. Epinephrine can be used, but if it is used as an upper GI bleed, you need to use another therapy along with that. A combination therapy which should be used. But remember, while using epinephrine in the rectum, you avoid injection in hemorrhoidal vessels, which may drain directly into systemic circulation. Diverticular bleed through the scope endoscopic clips work the best, and after, if somebody wants to apply over the scope clips, they may also be used. Angioectasias bleed, non-contact thermal therapy with APC. Post-polypectomy bleed, mechanical clip or contact thermal therapy. But remember that APC settings for colon require lower gas flow and power as compared to upper GI bleed. Now, coming back to a patient, just to remind you, this patient underwent upper GI endoscopy, had varices, but no blood out there. Colonoscopy, continued to bleed. Colonoscopy showed blood coming proximal to the ileocecal valve. So this patient was, but we kept on thinking that this patient has cirrhosis, so it should be an ectopic varus or a varicose bleed somewhere or something like that. So we went ahead with CT photography. So CT photography showed, now this shows paraesophageal collaterals in CT photography, but at the same time it showed active contrast extravasation, which was seen in one of the ileal loops. This is the active contrast extravasation which is seen in the ileal loops. Following CT photography, this is again the contrast which is coming out. The patient was taken up for digital subtraction angiography, because we thought that once we have found an extravasation source, so super selective cannulation and subsequently embolization should be useful. So DSA was done. Now DSA showed that ileal branches ending into vasa recta, two suspicious vessels were going seen beyond it, but overall the super selective cannulation, in terms of, it was not very clear whether there was bleeding from there or not, and overall embolization could not be done. By this time, the patient had received 8 units of PRBCs and FFPs and platelets. He had already had serum creatinine of 2.6 at onset. He had underwent hemodialysis also following CT prior to that, and again after CT also, but he continued to rebleed. So the question was what to do. But before I move on to the next step, what to do, let's talk a little bit, since this patient underwent CT and angiography and embolization, a few slides on that. Main advantage of angiography and embolization is it can control severe bleeding without bowel preparation. As I told you, unstable lower GI bleed, if you want to do a colonoscopy, bowel prep is required. You will not be able to do bowel prep in unstable lower GI bleed, will be very difficult. So there you can go ahead with CT angiography followed by DSA. Why CT angiography? Why not straight away go with DSA? Why? Because CT can really pick up the bleeding rate at more sensitivity is much higher, 0.3 milliliter per minute. Angiography 0.5 milliliter per minute. So in other words, if a patient, so CT angiography is reserved for patients who are having brisk ongoing bleed, who do not respond adequately to hemodynamic resuscitation efforts and are unlikely to tolerate bowel preparation early colonoscopy. So you may do CTA. At times you may straight away take up the patient for angiography. And if you're going to take up the patient for angiography, you find a lesion out there, then embolize it with platinum coils, n-butyl cyanoacrylate or alcohol. Remember that empirical embolization only in a case of malignancy. Like in this case, we were not very sure, so embolization was not done. Empirically, embolization could have been done, but empirically, embolization, why it is to be done only in a case of malignancy, preferably most of the times, because bowel ischemia is a commonly reported complication after embolization, 7 to 24%. So you would like to be sure before you go ahead with embolization. And even after embolization, there may be a rebleed. Short-term rebleed rates are 10 to 15%, whereas 2-year rebleed rates are around 25%. In other words, even when you embolize, the sequelae may include bowel ischemia, sequelae may include short-term rebleed, sequelae may include long-term rebleed. Now, important thing out here to notice that it is not that you do a CT angiography today and 2 days later you take up the patient for digital subtraction angiography. If the patient is unstable, then in general it is said that should be taken up within 60 to 90 minutes. And if the patient is not very unstable, then also you should be very clear that if you have done a CT angiography, you have picked up a lesion out there, your chances of embolization with catheter angiography would be maximized if you do it as soon as possible after a positive CTA. This is very important. Often what happens is we see that if the patient is marginally stable or becoming stable, then CT angiography is done and DSA is done 1 or 2 days later. And then you find DSA does not pick up the lesion at all. So everybody is wondering what happened. What about if no cause is found even on angiography, colonoscopy, upper GI endoscopy, everything done? Nuclear scan used to be done earlier, but generally not done because the localization is very poor. I would request my panelists also to comment on this, how frequently they do it. Capsule endoscopy in such cases obviously would have to be done, but remember capsule endoscopy is now it comes in the realm of more of obscure GI bleed. It is no longer lower GI bleed. So capsule endoscopy would be done within 48 hours of rebleed. The diagnostic yield would be maximized. It drops to below 50% if performed 72 hours after presentation. And obviously, once you come to obscure GI bleed, you have to go on for enteroscopy. And if the cause in lower GI bleed is not found, you go in for surgery and intraoperative enteroscopy. Indications for surgery, lower GI bleed. Surgery is again the last resort still, because now we have many centers which have angiography facilities available. Colonoscopy is available at many centers. So surgery is now becoming the last resort. Surgery, the indications are bleeding sources have been clearly identified, but non-surgical interventions have failed. Patient continues to bleed. If there is lack of a diagnosis despite a thorough workup using endoscopic and radiographic modalities, like in our case, we have done everything out here, upper GI, colonoscopy, CT photography, DSA, still we are not very sure where the patient is bleeding for. So this patient underwent surgery and intraop enteroscopy. Intraop enteroscopy, the finding was this. Base of Meckel's diverticulum, there was a thrombosed vessel which was present. The intraop findings were, the surgical findings were liver nodular, 1 liter of ascitic fluid, full of clots, ileum and jejunum, Meckel diverticulum present, 150 centimeter proximal to IC junction. The section of Meckel's diverticulum was done, ileal anastomosis was done. So these are the discussion points which I have covered till now. Initial assessment, diagnosis. Very briefly, I'll cover 2 other points, medications and surgery. So what is the role of repeat colonoscopy? If there's recurrent bleed, as I told you, there's a possibility of recurrent bleed. So again, recurrent bleed occurs in around 20% of cases, which may be early while in hospital or when the patient is discharged. You need to repeat the colonoscopy and hemostatic procedure. This is a very important, interesting case study, and subsequently RCT has also done. This is for patients with divertical bleed, and particularly for our country, it may be very interesting. This may be a good modality, although we have not used it at our center, but I thought that I'll put in 1 or 2 slides for this. Therapeutic barium enema for diverticular bleeding. High-dose barium impaction therapy is used using 200% barium sulfate if you are suspecting diverticular bleed. What happens is that you have a colonoscope. On a colonoscope, you put in or an enteroscope, you put in the over tube. So you, with the enteroscope, you go in cecum, you leave the overtube out there and come out. Subsequently, you attach the overtube with a connector through which you can flush in barium, and you give high dense 200% barium sulfate solution, and in between keep on inflating the overtube balloon and keep on withdrawing the overtube so that you inflate it after every 10, 15 centimeters, 20 centimeters, and keep on withdrawing it. So as a result, the barium, it gets impacted. So whenever there's a diverticular or something, the diverticular bleed will stop with the result because of barium impaction. This seems to be a very innovative strategy and seems to be, I would say, a cost-effective strategy also. Now, coming to concomitant medications, as I told you, lower GI bleed often occurs in the setting of ischemic heart disease, atherosclerotic disease, and all chronic kidney failure. So these patients are often on concomitant medications. What do you do about them? And these are the drugs which we also talked about, which predispose to bleed. So aspirin, if the patient is on for aspirin for primary prophylaxis, it has to be stopped forever. If a patient is on aspirin for secondary prophylaxis, may be continued or discontinued for 5 to 7 days. If a patient is on aspirin plus clopidogrel, within 30 days of bare stent placement, you have to continue both of them because the risk of thrombotic complication is much higher. If the patient is again on dual antiplatelet therapy within 90 days of acute coronary syndrome, again to be continued. You consult the cardiologist, but should be continued. If a patient is on dual antiplatelet therapy within 1 year of drug-eluting stent, 30 days of bare stent, 1 year of drug-eluting stent, again to be continued. When the patient is having, that is, hemorrhage is there, it is to be continued unless until the patient has very severe hemorrhage, then you talk to the cardiologist and see if you can stop it for 2-3 days. Beyond this time, if a patient is on dual antiplatelet therapy, you can easily stop clopidogrel, stop it for 7 days, you restart it after 7 days. You can even hold it on for more than 7 days and restart it for their aspirin, as I said, may be continued. So in other words, this table clearly tells you that within 30 days of stent placement, within 90 days of acute coronary syndrome, or within 1 year of drug-eluting stent placement, do not stop dual antiplatelet therapy. Rest of the times, stop clopidogrel and you can restart it after 7-10 days. If the patient is on warfarin, stop it. If the patient has a low thrombotic risk, that is the reason for which the patient was on warfarin, you start warfarin after 7 days. However, if the patient has a high thrombotic risk, like was on warfarin for mitral valve prosthetic, atrial fibrillation with mitral valve, or had venous thrombolism in the last 3 months, then in that case, you may consider heparin bridge therapy, although that may not be useful. You may put the patient on low molecular weight heparin therapy 48 hours after heparin. If the patient is on direct oral anticoagulants, you have to stop them. You may give inhibitors like idarucizumab and andexanet, and if the start after 7 days after bleeding stops, dabigatran change to apixaban, because that I told you is the least risk of lower GI bleed amongst the DOACs. Or you may also consider reducing the dose of dabigatran to 110 milligram BD. So summarizing, if a patient presents with acute lower GI bleed with appropriate assessment and fluid resuscitation, calculate shock index, heart rate by systolic BP. If the shock index is more than 1, classify it as unstable lower GI bleed. If the shock index is less than 1, consider it as stable lower GI bleed. If it is an unstable lower GI bleed, it may be preferable, if you're not able to stabilize the patient, that the patient should be taken up for CT angiography. If the patient has a stable lower GI bleed, then you calculate the Oakland score. Oakland score is available on MedCal, so you can calculate it within a minute. For less than that, as I told you, simple variables, age, sex, hemoglobin, heart rate, blood pressure, previous history of lower GI bleed. So if it is more than 8, admit the patient and go in for colonoscopy. Colonoscopy we talked about, 24 hours colonoscopy to 24 to 96 hours. The rates of picking up lesions, rates of hemostasis, transfusion, they were all the same. So you need not rush in for a colonoscopy. If the Oakland score is less than 8, that means minor risk, stable patient, minor risk, send the patient home and you can have the patient investigated on an OPD basis. Do a colonoscopy still for sure, because you would like to rule out a malignancy, particularly if somebody is more than 50 years old. Here on CT angiography, you pick up the lesion. Interventional radiology team should be available within 60 to 90 minutes. The patient is unstable, otherwise as soon as possible. Embolize, successful embolization, yes. will require admission and subsequent colonoscopy to assess lesions. Subsequent embolization, no. To go in for surgery and other measures. So newer concepts which we have over the last 5 years for lower GI bleeders, that we have predictive scores for severe bleed, which are very simple to use, which really help you to triage in any setting. They can help you to triage in from a, I would say, from a primary setting to a tertiary setting. Clinical significance of CT angiography before colonoscopy. There is a definite placement for that now. Earlier, we used to all rush in for colonoscopy, but now it is clear there's a definite placement for CT angiography. Timing of colonoscopy is not so important. Bowel preparation is very important. There's no point doing an unprepped colonoscopy. Management of direct acting oral coagulants is much more clear to us, and we are much more wiser about it. Thank you so much for your attention.
Thank you, Dr. Vineet. It was a wonderful lecture, and you covered. More importantly, we saw first time many new concepts, especially the use of cross-sectional imaging in GI bleed, which was up till now neglected, and it was fantastic lecture. I think we all were spellbound. I was really very impressed by the newer things which you presented, and I think to go further, I think there are some topics like you presented a case with who has GI bleed with a hemodynamic instability, but there are other type of GI bleed also, like patient presenting to us with iron deficiency anemia. They have not overt bleed but occult bleed. So I think I'll invite my panelist, Dr. Dev Kumar and Dr. B.M. Dayal. How do you approach such cases once you see a patient who has iron deficiency anemia but have no overt GI bleed, and they never have melena or any hematemesis previously? Dev Kumar, can you suggest that? Do you do occult blood test, or what type of occult blood test you do, or you do other inflammatory markers?
Yeah, I mean, first, most important as a surgeon, I take a detailed history of the patient. I mean, whether they have an altered bowel habit and things like that, to rule out the malignancies. Then hemorrhoidal history is very easy to take. I mean, they say as soon as they defecate, they bleed. If they don't defecate, they usually don't bleed. But if somebody presents just with an anemia, then the most important thing I look for weight loss with anemia. And so if there's a weight loss, that and all anemias, we should always go for top and tail, like your otherwise will miss a lot of lesions. Normal tendency, I see the people with anemia, especially in India, I mean, the general practitioners, and they don't give a damn to anemia, they just give iron supplement. And patients go on iron supplement, they improve their anemia, and then forget about it, then they come back in. So that delays the diagnosis of the sinister pathologies mostly. So yeah, top and tail should be done, like an upper GI and a colonoscopy should be done as a part and parcel of anemia investigation. And first, you already get this anemia. So, but if some people come low hemoglobin, then you should do a full profile of your complete blood count, and also do iron, TIBC and all the stuff. But as you said, it's an iron deficiency anemia, so there must be some blood loss. Fecal local blood, yes. I mean, sometimes, in very elderly people, like colonoscopy, I consider is a bit traumatic to them. You can have a ruptured colon at times, so they have a very thin colon. So yes, that you can at least do an upper GI and a fecal local blood can be done, 3 fecal local blood. But only problem with fecal local blood, there's a false positivity. Like you need to give them a clear instructions what to eat or not to eat. And even that brushing your teeth can give you a fecal occult blood positive. So these are the things you should tell them clearly, how to be prepared for a fecal occult blood test.
That's a very important point which you have made, Dr. Dev Kumar. I'll go to Dr. Dayal. We have a lot of problems telling patient eat this, eat that before doing a quick test, occult blood testing. Do you think immunochemical test that the fit test a better choice in this situation? Dr. Dayal, you have to unmute yourself. Still, we can't hear you. So you have muted your. Yeah.
Okay.
Yes.
Yeah. So I think the fecal blood tests, definitely the GUAC blood tests have got a lot of these false positivities and confounders. And immunochemical tests are slightly better. But in our situation where you are suspecting that this patient's anemia is because of occult GI bleed, occult obscure GI bleed, uh, I don't think that the fecal blood tests are very good at picking this up, because there was a meta-analysis which showed that the sensitivity was pretty low, barely about 50 to 60%. So fecal occult blood tests are not very useful in this particular situation. But fecal calprotectin could have a role. I mean, there's very limited data, but fecal calprotectin can pick up inflammation in the small bowel, which could be leading to some small leaks, which is leading to the iron deficiency anemia, or the disease like Crohn's disease, which is associated with anemia. So in that situation, I would suggest that we can use, if you have the choice, to use fecal calprotectin rather than fecal local blood tests.
Dr. Vineet, do you agree that a fecal calprotectin should be the initial test of choice rather than immunochemical test?
No, what Dr. Dayal is saying is correct, that FCP will be good for inflammatory lesion, but if the setting is iron deficiency anemia, then in that case, and in the sense, stool for occult blood should be the first choice, because it will pick up blood loss not only from colon but also from the small intestine. The
Yes.
immunochemical test, the problem is, one, it is not available readily. I'm not sure where all it is available, because in Delhi at many places it is not, right? And secondly, it will pick up only the blood loss from colon. It is a test for ruling out colon cancer. It's a screening test for colon cancer. So that is an essential difference. So if you want to rule out small bowel GI blood loss, you have to do a stool for occult blood if you have to rely upon the screening measures.
So that is what exactly point was when we have a patient who has iron deficiency anemia and we want to zero down where is the etiology. Capsule endoscopy is a very, very costly test, and we don't have any guide whether we are dealing with blood loss or not. I think fecal occult blood test is a very good test to begin with, to pinpoint that, okay, we are now going to test the small bowel. So definitely it has got a role, and of course, as Dr. Dayal told, in Indian scenario or in a younger patient, it is the inflammatory bowel disease which is responsible for GI blood loss more as compared to angiodysplasias or dulophy lesion in older patient or in West. I think fecal calprotectin test also can be a very, very important handy tool to at least to begin with, to concentrate our area of interest. I think these are very important tests. Now, once we have decided that there is a mid GI bleed, a patient who has iron deficiency anemia or who has melena and who has upper GI normal, colon normal, now we want to evaluate small intestine, because this is now a mid gut bleed. So what will you do first, Dr. Dayal? Will you choose a capsule or will you do antroscopy first in this situation?
Actually, both capsule endoscopy and enteroscopy have an equal diagnostic pickup. And enteroscopy has the advantage that you can do, if the patient is actively bleeding, you can do some therapy as well.
Yes. So I think it is very important. Though the diagnostic yield is equal, but the therapeutic possibility with enteroscopy is better. So if a patient who has come to us with GI bleed and is hemodynamically unstable, who requires quick action also, we should always go with a modality which has got a diagnostic as well as therapeutic capabilities. Angiography is the one which has been shown to be effective, but angiography requires a very brisk bleed, more than 0.5 ml per hour, as Dr. Vineet has already told. But if that is slightly lesser than that, we may not have a positive angiography, whereas the Dr. Vineet's case was there. They have shown extravasation on CT angiography, but once they went with angiography, it was negative. So I think in such situation, antroscopy is the choice. When there is a hemodynamic instability, but when patient is stable and there is iron deficiency in anemia, no point in going with antroscope. Antroscope is a cumbersome procedure. It's a long procedure. Balloon assisted antroscopy requires 2 hours to 3 hours. And on top of it, if you don't find anything, there is no point. So capsule endoscopy is the first choice when patient has iron occult bleed and patient is hemodynamically stable. Antroscopy is first choice when patient has overt bleed and there is some hemodynamic instability.
And one point I'd like to add, especially in the patient with the stable bleed, it has been shown that the capsule endoscopy prior to enteroscopy increases the yield of the enteroscopy. You can focus the endoscopy.
But also it guides us to take which route, because enteroscopy can be done from antegrade method and a retrograde method. So antegrade method, if, as you told, capsule endoscopy, if the lesion lies in first 75% of the total time of capsule endoscopy, you have to choose antegrade enteroscopy to assess the cause of bleed. That's a very important point we have made. So now we have a patient who has GI bleed, and we are doing this investigations to pick up the cause. Will you start tranexamic acid? Is there any role of tranexamic acid, Dr. Devkumar? Do you believe in that?
No, I don't think
But
so.
you are a surgeon. You are a surgeon. Many trauma patients have been shown to be very, very. The mortality is improved.
The only scenarios where this tranexamic acid has been proved is your the trauma setting, if it is given within 3 hours, and in postpartum hemorrhage, and even for surgeries like orthopedic surgery. These are only 3 settings. The tranexamic has got no role. Interestingly, because I got those questions as doing some research, the HALT IT trial has just published and in Lancet, and that has completely ruled out. It's an extensive trial of 12,000 patients over 164 hospitals throughout the world, including Pakistan and all. And that has showed there is no role of tranexamic acid in GI bleed.
That's very important. And in fact, tranexamic acid was associated with increased venous embolizations.
Yes, and also it increases VTE. Venous thromboembolism risk is increased. So that's got no role, but which is a common malpractice. I think every GI bleed, even the piles bleeding, they get pause tablet. So
that is now clear that those patients who has come to us with obscure GI bleed and we are not able to find out any cause and we are not able to do endotherapy, there is no point in giving tranexamic acid.
There is a reason they have shown in that paper that if the bleeding starts, suppose now bleeding starts, and if you give tranexamic acid within 3 hours, so then it works because there is some fibrinolytic pathway theory is there. So what happens basically in orthopedic surgery, we know the timing of bleed. In trauma, we know the timing of bleed, and in postpartum hemorrhage, you know the timing of bleed. But for GI bleed, we don't know the timing.
Yes.
So it doesn't work.
Yes. So, Dr. Dayal, what works suppose we have obscure GI bleed and we know the most common cause in elderly is AV malformation. So, is there anything available to us when we don't have the gadgets to reach to the small bowel, and at least we can start something? What is the literature?
Yeah, there are certain drugs which could be useful in this situation. The most important of them are the long-acting somatostatin analogs.
Yes.
Octreotide itself can be used, but it is cumbersome to use on a daily basis. But long-acting, like some LAR octreotide or landiotide, they can be given once a month,
yes,
and they have a good effect. the average clinical response is around 3/4 of patients respond to this therapy. And the plus point with them is there are very minimal side effects. Over long-term use, there could be some hyperglycemia, gallstone disease, etc., but they're less.
Yes. So this
And-
old good friend for neuroendocrine tumors, which we use, is also effective in this type of patient.
Yeah.
What about other drugs like hormonal therapy or other angiotensin enzymes which are there, anti-angiogenic thalidomide?
Yeah. Hormone therapy is not discarded because it is not shown any response in the RCTs. But the old thalidomide, which is the bugbear causing phocomelia, amelia, way back in the 50s and 60s, is back now, and it has been used in like in leprosy, in multiple myeloma, and several other malignancies. But it has got effect on, it inhibits the vascular endothelial growth factor. And so it has got a definite effect even in these patients. The only problem is that it has got a lot of side effects.
Yeah.
A lot of side effects, and some of them are minor, but there are some significant side effects, like it can cause neuropathy.
Yes.
And it can also cause acute liver failure. It can cause thromboembolism. Lenalidomide is more effective, less toxic, but then it's got one major side effect, that is bone marrow suppression. So if the octreotide and other analogs don't work, then these compounds are the second line of agents which could be tried.
Yes. So that's very important pharmacological management. And one of the important point which Vineet raised was about radionucleotide scan. Now he showed a case where luckily they have a CT angio picking up extravasation. But we have many patients who come to us with GI bleed, and we want to localize the part. What is the role? Do you use, Dr. Dev Kumar, in your clinical practice?
No, I've never seen using or never used it because it gives a very gross idea of it doesn't localize exactly. So actually, I don't think, except the Meckel scan, nothing helps. Like RBC scan, technetium RBC scan, if you can do suspect Meckels, then probably yes. Otherwise, no value.
Dr. Dayal, do you use?
No, we don't use, but in terms of, like Dr. Dev Kumar said, in Meckel's diverticulum, it is a disease of children or young adults.
Yes.
And the other modalities, like we have C2 enterography or capsule endoscopy or balloon enteroscopy, they're not well suited for this class of patients.
Yeah.
For kids. So in that situation, I think Meckel scan still has a place.
Meckel scan, no doubt we will use, but I'm talking about this autologous technetium RBC tag scans, which are used.
No, I don't think they're of much use in the current context.
Yeah, I agree with you, and they are very vague, and they do not have a good localizing ability. Though some studies have shown that if you do a RBC scan and RBC scan is positive, the chance of angiography being more positive is very, very high. But I think we have got a very good modality like CT angio, which also tells us that if CT angio is more sensitive, it picks up the extravasation, then chance of angiography being positive and arrest of bleed with angiography is positive. So I think the thing which was being told by RBC scan is, I think, is taken over by CT angio. Vineet, you have any point in this regard?
The detection rate is actually equal, nuclear scan and CT angio.
Yes.
One, and number two, localization, as we all know with our previous experience, that if the bleed would be on the right side, it would be showing on the left side.
Yeah, by the time peristalsis will push it to a different place. So yes, so I think in clinical practice, these modalities have no role now. I think Vineet has quite well covered the platelets and anticoagulant, when to stop and when to start. I think one has to take a good balance between how severe is the lesion, like in duodenal ulcer, we see forest classification, and also in LGI bleed, the scoring system. But also we have to take care of how is the risk of thromboembolization once you stop antiplatelet or warfarin. You patient may not die of bleeding, but they will die of these cardiovascular or neurological problems. So it is very important to err on the side of continuing anticoagulants and restarting them quickly if the risk is high as compared to stopping them. So I think we'll go to the questions raised uh, by our viewers. And the first question which I will ask from Vineet is, what is your personal experience regarding management of multiple angiodysplasia of small bowel with thalidomide or long-acting octreotide? I think Dr. Dayal has already told us. Is Dr. Sodha from Bhuj, and he has clearly told that long-acting octreotide is the pharmacological drug of choice in this scenario, and you can also use thalidomide, but there is no role of hormonal therapy. There is no role of tranexamic acid. So this is clear. Second question is from Krishna Kumar Arora. What are the extra intestinal cause of lower GI bleed? Vinit, will you
I
take this
think,
question?
I think what I understand from this question is like maybe like one is drugs, which we talked about, the drugs which can cause lower GI bleed. Second is chronic kidney disease. Third is, as I talked about, ischemic heart disease, patients of atrial fibrillation because of the drugs which they would be on. Then besides that, uh, would be patients like portal hypertension again because they could be having ectopic varices or something like that.
Yes,
Post
yes.
radiotherapy. So
And I think one very important cause of once we are doing evaluation of obscure GI bleed is always to do a side viewing endoscopy, because sometimes patient with hemobilia or hemosuccus will present as melena, and you will do any test, you will not find. But the moment you put a side viewing endoscope on papilla, you will see intermittent blood coming out of there. And then this is a very important extra intestinal cause of GI bleed, and one has to do this. And most of the time, you will pick up the diagnosis by doing a good CT scan, when you can find an aneurysm in the hepatic artery, or you may find a splenic artery aneurysm, and you can have they are real obscure, and a good CT scan. And most of them are hemodynamically unstable. And as Vineet has shown us, if you follow that protocol of unstable disease, you have to do a CT scan. And this type of disease can be easily picked up by doing a CT scan early in the algorithm of diagnosis. Uh, Vinith, you had very nicely talked about resuscitation. And the next question from Harish Darak from Mumbai, he is asking, what is the target blood pressure for fluid?
it should be
How
around.
much fluid should you be given, and rate of infusion?
That will again depend. Target would be mean arterial pressure. You put the mean arterial pressure above 85 and all. And the basic thing is that how much fluid should be given will depend upon the severity of the bleed. Rate of infusion, obviously, at times you have to push in blood, you have to push in fluid. Depends upon the how much hypotension is there. So I don't think there's any definite answer for that. It depends from situation to situation. But the whole thing is that the mean arterial pressure, the moment it dips below 65, you know you have to act and you have to get the mean arterial pressure up. That would be the target BP for fluids. Again, depends if the patient is on antihypertensives, beta blockers, and all. Then your targets may keep on changing.
Arun Chakravarti from Kolkata, he is asking incidence of lower GI bleeding following antiplatelet, prasugrel, clopidogrel. Your experience in the practice, do you find them very commonly, Vinit?
Yeah, in the sense that you do find these patients to be having bleed. They may not be having uh, what overt GI bleed, they may present just with iron deficiency anemia. At times they present with also overt GI bleed. You do find them, and as I showed that aspirin, the least risk, clopidogrel, higher risk, prasugrel, the highest risk amongst these drugs. So definitely the risk of bleed is there. And if you're giving a combination dual antiplatelet therapy, then again, as gastroenterologists, we stop clopidogrel. Although if you go according to cardiologists and if you go according to the trials they published in their journals, they would stop aspirin rather than clopidogrel. There's a confusion. Okay, but in general, I would say right now to underline it, stop clopidogrel, continue with aspirin.
Yes. Shubham Jain from Mumbai is asking for obscure GI bleed, should CTA be preferred over capsule?
So that's a good question, because obscure GI bleed, if the patient is, the rate of bleed is less than 0.3 ml per minute, then the chances of finding anything on CT angiography would be low. But again comes the question out here that if you do a capsule endoscopy without looking at the anatomy and the capsule goes and gets stuck, that is a problem. So in such a case, for example, if a patient is having iron deficiency anemia, as you talked about, patient is having occult GI bleed, there instead of doing a CT angiography, my first choice would be CT enterography, because I would like to see if there's any mucosal involvement, any stricture out there, and if I do not find anything that would give me information, then I would proceed with the capsule endoscopy.
And can
So
I add
the CT angiography,
lot of times we pick up gist by doing
Yes,
just
yes, yes. That's
Right.
very important. Very important.
Yeah.
It's very important. Also, I'll go to because there are many questions. I'll quickly go to Arun Chakravarti from Kolkata. What is the pathogenesis of bleeding in the cases of iron deficiency anemia? I mean,
these are the causes of iron deficiency anemia, like worm infestation, any kind of ulceration out there. So obviously, because of that, there is constant blood loss, and since there is constant blood loss, I think that's so. The first thing is loss of hemoglobin. So loss of hemoglobin, there would be iron deficiency.
yes. Gautam from Hyderabad is asking, overt obscure GI bleed. If enteroscopy is not available, what to do?
Capsule, as if overt obscure GI bleed, then in that case again CT scan and capsule. And capsule, as I talked about, done within 72 hours or within 48 hours of the onset of bleed, the chances of picking up are the maximum. Although there is a little bit of debate, because some people feel that blood will obscure the site of lesion for capsule and enteroscopy may be a better choice. But overall, in general, the conclusion seems to be veering more towards doing capsule first rather than enteroscopy, which I don't know, Mohan. What is your take on that?
I think we definitely try to go. Here the question is when the enteroscope is not available. But
okay, then you have to do a capsule.
Then you have to do that. But in practice, which we are having a problem is that how to quantify 0.5 ml per minute in clinical presentation. That is a big
So if the patient is having shock index, that means that it is more than 0.3 ml.
Oh, that's very good. So that takes care of, that's a very simple clinical calculation that if shock index is more than 1, CT angio is the modality of choice, because
very high chance it will pick up the lift.
Yes.
70% chance, 60-70%.
That's very good. Arun Chakravarti from Kolkata is again asking role of somatostatin in GI bleed, as we have already talked about. And you talked about CT photography. He's asking what are those?
So if you want to look at if you're having a case of portal hypertension, you want to look at portal venous anatomy, you're looking for ectopic varices and all, then you want to look for what are the shunts out there, then you do a CT photography. In this case, since we had a case with cirrhosis, and somehow that's what I wanted to show you, that it was a real life case, that how you get stuck at times. No, even the patient was having maroon blood, but he's having cirrhosis, so he has to have ectopic varices. Right? So that is why we went ahead with CT.
So in a case of portal hypertension, I think CT photography is a very good choice, because you need to point out the ectopic varices. Sanjay Kumar Singh from Ghaziabad, he is asking, in patients with heart failure, which fluid and how much fluid should be used? I think you talked about blood transfusion, where you said 9 grams should be the cutoff in patients who have heart disease. What about the fluid?
I think the best answer for this is that a resident should be able to give this answer, who is very close to internal medicine, or one should consult a cardiologist, because obviously if a person is with heart failure, there are many things which need to be managed. And again, I may not be the best person to give the answer. But again, don't give colloids. They give crystalloids. That's the only thing I can say here. And the one another thing, what you can watch for overfluid overload in such cases is do an ultrasound. Look at the IVC.
Yeah.
And if you find that the IVC, in the sense you look at the contraction in the IVC, that really helps you in deciding whether the patient has less of fluid or the patient is going into fluid overload. That may be a good guide to decide how much fluid you want. And a bedside ultrasound done in an ICU can easily pick it.
Yeah. So now I think we are seeing more and more our intensivists using ultrasound as a guide to the quantity of fluid rather than JVP or the central venous pressure. They take, as Vineet has told, the IVC filling as a marker of fluid overload. So I think I'll go to the last question, Vineet. We are almost 20 minutes ahead of our schedule. The role of guaiac-based fecal blood test in patients who is taking iron. So does it affect it?
Yeah, in the sense that generally supposed to be avoidable. That if a patient is on iron, you would not give it, because there are certain reagents. Earlier, it was clearly thought that it is a no-no, that if you are going to use a guaiac-based test, then it will cause false positive red meat, iron tablets, and all those things will cause. Some new reagents did come up, but in general, if you're sending a patient for stool focal blood, take the patient off.
I think the color change also will cause false positive reading rather than false positive test per se, because guaiac test reads enzymes which iron tablets will not affect, but the color change will that will be, they will be false positive, read as false positive. Yeah. So always try to avoid iron tablets when you are doing guaiac test.
That is precisely the reason FIT came up.
Yes.
Because FIT does not get affected by any of these variants.
Any of these, yes. So I think with this, I'll thank Vineet, Dr. Dev, Dr. VM Dayal, and Dr. Sujit Chaudhary, and all other people backstage who has made this panel discussion and Vineet's wonderful lecture possible. And I think with the question which we had all over the country, people were watching. And thank you, Vineet, and thank you all the panelists for this wonderful opportunity.
Thank you, Mohan, for moderating it so well, so nicely. Thank you, Dr. Dayal. Thank you, Dr. Ray. Thank you.
Thank you, Vineet. Thank you.
Before we end, I would like to thank everyone. I liked Dr. Vineet Ahuja's lecture, and especially the shock index. I think that is the key point of learning from this lecture, and the clinical based algorithm, which I liked most. And I would request Mr. Jogesh Ahuja, GM Lupin, to have a couple of words at the end of the session. Mr. Jogesh Ahuja, please.
Yeah. So good evening to all the doctors. On behalf of Lupin, I would like to thank Dr. Sujit Chaudhary for giving us this opportunity to be associated with Gemas. At the same time, I would also like to thank Professor Vineet Ahuja for such a wonderful oration, and definitely the wonderful presentation and oration from Dr. Vineet Ahuja. I would like to thank our eminent panelist, Dr. Devkumar Rai and Dr. VM Dayal also. And definitely the whole thing was summarized in a very, very beautiful way by Dr. Mohan Ramchandani also. So a big heartfelt thank from Lupin to all of you once again. In Lupin, we always believe we are very keen rather to be associated with such scientific bodies and be participative in such CMEs and webinars. Lastly, I would like to thank to all the viewers, all the doctors who have connected to this webinar from the different part of our country. So with this, I once again thank Gemas, Dr. Sujit Chaudhary for giving us this opportunity, and definitely last not the least, Dr. Sudipto Ghosh for giving us this opportunity to be connected with in this webinar. Thank you all once again, and good night.
Thank you so
Good
much.
night.
Night.
Good night.
Good night.
Okay.